Can you hear me now, as they say?
Yes, you're all good, Dr. Williams.
I was saying, thank you, Ram, for your inspiring call to action. And one of the times when all patients face some risk for gaps in care is when they transfer between pediatric care and adult care. And so our panel is going to address this issue, which is especially difficult for those patients who are underrepresented minorities. So the first panelist in this excellent group, Dr. Wayne Franklin in Phoenix, Arizona. He is the ACHD director and co-founder of, co-director of the Heart Center at Phoenix Children's Hospital, and he's a professor at the University of Arizona School of Medicine. We have Dr. Stephanie Fuller, who's an attending surgeon in Philadelphia. She's board certified in general surgery, thoracic surgery, and congenital heart disease surgery. And she operates on children at Children's Hospital of Philadelphia and adults at the ACHD Center at the University of Pennsylvania. Ms. Jennifer Iguina lives in Orlando, Florida. She is a mother of 3, and her youngest son, Lucas, has hypoplastic left heart syndrome, and he's 13 years old. And Jennifer is the founding member of Conquering CHD in Florida. She's a very active advocate for the Hispanic community. Dr. Kylo Lopez is a pediatric cardiologist at Texas Children who has done a lot of important research focusing on healthcare disparities for minority and underserved children. And her work brings together the field of cardiology with public health and health policy to improve the care of minority and underserved children. Dr. Sasha Opakowski is director of the ACHD program at Cincinnati Children's Hospital. And he, in Boston, founded the ACHD Biobank at Boston Children's Hospital in 2012. And he collected specimens for over 1,600 patients. He is now professor of pediatrics at the University of Cincinnati. Ms. Rosalyn Rivera is living with congenital heart disease. She's a pediatric cardiology nurse and outpatient coordinator at UCLA Mattel Children's Hospital. Previously, she was nurse educator at William Novick Global Cardiac Alliance and traveled to developing countries to provide post-surgical ICU care and medical staff training. And she's actively involved in our Camp del Corazon in Southern California and is advisor to their adult congenital heart disease program and PACE, which she'll explain. Ms. Jennifer Weiner is an adult living with congenital heart disease. She is an active advocate for teens and adults in care, to keep them in care, and currently serves as director of ACHD at Conquering CHD. So with this panel, I'll start off with some questions that we have posed in advance, and we will go on to take questions from the audience. So the first area that we're going to address is that of the workforce of those caring for adults with congenital heart disease. And so since the adult patients outnumber certified ACHD specialists by 4,500 to 1, Wayne Franklin, what implications does this have for adult CHD patients and their families?
Well, thanks, Dr. Williams, for the introduction, and thanks everybody for having me. Sounds like it's been a great start to the conference. I'm going to defer to a slide that you gave probably 20 years ago, maybe, Dr. Williams, when you talked about the number of pediatric cardiologists compared to the number of adult cardiologists. And back then, it was about, I think it was 23-1 more adult cardiologists than pediatric cardiologists was the ratio. So pediatric cardiologists are greatly outnumbered by adult cardiologists. But as Sasha and some of the other folks on this call would probably agree, a lot of the adult cardiologists are not trained to take care of adult congenital heart disease. At least I'm sure 20 years ago that was the case. And throughout my career, I've tried to train a lot of the adult cardiology fellows. We've grown from probably not training any to training, I think they initially had 6 hours during their 3 years of training, to in many programs now, the COCATs and some of the cardiology fellowship, they have to be 1 month. So I think everybody on this call would agree that 1 month is woefully inadequate to really consider yourself an adult congenital disease doctor, but at least we're growing, because we realize that pediatric cardiologists can't do it all themselves, and they shouldn't have to, because they're not trained, most of them aren't trained in adult congenital. We now have a fellowship, of course, and a board certification, but they generally want to stay with kids and with babies. So we're trying to train more of both pediatric cardiologists, but really at least expose the adult cardiologists to this field, to this problem, so at least they'll have a general understanding of some of the basic physiology. That's one approach.
Well, that's excellent. That brings up an issue I'd like to ask Stephanie Fuller to maybe speak on, which is it's not just the cardiologist, but it's the whole team. And what are the essential members of this team that is really required to take full care of the patient? As Ram was talking about, you take care of the whole patient.
Yeah, thank you, Dr. Williams and Dr. Franklin. I think these are two really critical issues. Is not only is the ACHD cardiologist or surgeon appropriately trained, but then we have to think within the whole dimension of either a patient's outpatient or inpatient experience. So first of all, to start with surgery, there's very few congenital heart surgeons who perform over 30 cases a year on adult congenital patients. And that's really a relatively low number. It really tends to get less the more complex the cases are in nature. And naturally, we're seeing the most improved survival in patients who are not only the most complex patients, but also the most complex patients who have additional surgical needs. So that opens us into the realm of anesthesiology, for example. Is your anesthesiologist going to be familiar with congenital heart disease? And are they going to understand the nuances of caring for a patient under general anesthesia? Is your ICU team, either in an adult or pediatric hospital, going to be sufficiently balanced enough to understand what the challenges are for taking care of these patients in either a pediatric or adult environment? And this is particularly important when we talk about kind of the general issues associated with aging in our population, when these patients are relegated to a pediatric hospital, or the very particular nuances when patients are in an adult hospital regarding congenital heart disease, specifically those patients with single ventricle lesions. It extends true, I think, particularly across nursing and the knowledge that nurses need to have to share these patients. For us in doing our more complex single ventricle patients at the University of Pennsylvania, for example, we spend hours of training before incorporating a patient like that into the ICU or onto the floor to recover, just so that the people who are specifically involved in their care have in-time training regarding the anatomy and the physiology. And this really extends across the whole inpatient system. It's not just one person, it's the entire environment that needs to change. And that can also mean the environment in terms of the hospital system itself. So are the beds going to be adequate size? Hoyer lifts in a pediatric hospital, for example. Is the diet and the hospital menu going to be something that's palatable to an adult as opposed to a child in a pediatric hospital? So we have a lot of issues that I think need to be really well considered when you think of the patient as a whole, not only the cardiologist or perhaps the surgeon.
Well, let's stick with this topic for just a little while in terms of the specific requirement that a pediatric hospital might have to successfully care for adult patients. Wayne Franklin, you want to take a note for that?
Yeah, it's interesting. As a guy who's worked at a few pediatric hospitals in my career, I've seen it done several ways. But particularly when a pediatric or children's hospital is going to sort of get into the environment or start to take care of adults, they really have to have all of the medical care delineated. As Dr. Fuller mentioned, nursing is a big part of it, but at the end of the day, you got to have the right doctors, right? At least from the beginning, because you don't want to go in sort of, as they say, kind of half-stepped or incompletely prepared. For example, if you take care of adults, you're going to have to be able to take care of adult type problems. So pregnancy, alcohol use, lung disease, COPD, emphysema. We don't really see that in children. And so you have to be able to take care of that. And of course, there's sort of the adult type complications of the care we do, which is a stroke, embolic, or hemorrhagic, myocardial infarction, right, heart attacks. We don't see a lot of those in pediatric hospitals. So in my experience, those are the emergencies you certainly have to be prepared for, even if it happens once every 10 years, right? Any of those problems can just be devastating. And that's the ones you want to be prepared for. So I think in summary, you have to make sure you have the right subspecialists. You certainly need neurologists, a cardiac surgeon, interventional radiologists, but you also need the other things, nephrologists, GI, things like that. So I think really if a pediatric hospital is going to get into the business of taking care of these adults, they really should make sure they have adult subspecialists who at least can come in an emergency and probably even just come consult just for general medical care as well. And I think that's a good way to start.
Well, Kyla and Rosalyn, Kyla, you are in a freestanding but associated with Baylor Children's Hospital, and Rosalyn, you're in a free-leaning hospital that is part of the same system and the same contracting system for all of the other subspecialists as well. Would you like just to make some brief comments on that?
Oh, thank you for the opportunity, Dr. Williams. Happy to be here today. This is such an important topic. I will say, similar to what Dr. Franklin mentioned, as an institution, we have grown from a way of thinking of let's have these patients survive to let's have these patients thrive, because you can't just focus on the survival because that's no longer sufficient. And so as we've gone on and evolved in our process in taking care of these patients, other areas I think have come to light that really emphasize the need for having specific adult care, even in the confines of a children's hospital. And so at Texas Children's, we have now built the first ever floor/center specifically for ACHD patients. They have their own clinic space, they have their own floor space, they have their own dedicated nurses, they have their own dedicated ICU and floor beds. And it's the first time this has ever been done because we recognize that some of the things that we do in the pediatric space just are not applicable in the adult space and require, as Dr. Franklin mentioned, other subspecialists, require individuals who have specialization from a GI perspective or from an ID perspective that deal with adult issues, from a pulmonic perspective or anesthesia. And so we've done that to kind of increase the space. We've also done that in the space of having a specialization for women who have congenital heart disease, who get pregnant, having a specific core team of MFM or maternal fetal medicine specialists who work alongside adult congenital specialists to care for women during their pregnancy. And we've also kind of increased other areas in terms of improving the transition space, having a dedicated transition clinic to improve the space between one side and the other. And so we recognize that there is a distinct difference, and we are trying to make that difference a very distinct area, and saying, while we provide lifelong care, we have to recognize that there are nuances and differences between these two fields.
Thank you. And Rosalyn, you're at UCLA, where within a university hospital, it houses both pediatric and adult programs. Could you describe briefly how it works at your place?
Sure. So I think having that space, as you have mentioned, where the pediatric hospital is actually part of the adult hospital here at UCLA, we do have the opportunity and the privilege really of allowing some of our ACHD providers to come and meet our pediatric patients as they're getting closer to that age of transitioning or transferring over to ACHD care. We have a very robust transition program, including a transition nurse who comes to our pediatric clinic and meets with the patient starting at the age of 12 to be able to start that education a little bit earlier than 18 or 20, 21 when they're sent over to or transferred over to ACHD care. And then that also goes with our providers. So our ACHD providers are able to, my dogs, are able to come over to our clinic as well and meet with the patients and their families in pediatric clinic. And that goes to say that it takes a lot of coordination and collaboration between all those teams to make sure that the patients are seen in a timely manner and we don't miss them per se in the pediatric clinic. That being said, it's not always easy. And even though we have the physicality of being right next to each other, it is still can be difficult. There are still times where patients are referred to what we call our transition clinic, which is when they would meet the ACHD provider, but may not make those appointments, and then it requires some follow-up and things like that as well.
Thanks. And I think that there are obviously more than one way that this can work, and each way has its own set of problems, but there's a lot of geographic differences in terms of the availability, and making all of these systems work well is what our aim is, so that we can serve all people. Sasha, by the way, Sasha Opatowski is deputized to step in with me if I lose internet contact, because not only am I in a community with JPL that sucks all the terabytes out of the internet, but we're having a wind event, which usually brings us down a little bit. So Sasha, would you like to comment on what we can do to mitigate the shortage that we have in the number of particularly ACHD cardiologists, but the whole staff in general?
Absolutely, and I just the vice moderator, my internet just came off for a second there, so we might need to appoint a Secretary of State. But you guys can fight amongst yourselves when that happens. I think that this is a really good question and an important one, and I think a lot of it has to do with developing relationships and educating providers such that we can identify patients who really require care from an ACHD specialist and center, and that's not very easy. There's some things that seem quite obvious and probably are very complex congenital heart disease, but there are things that are quote unquote simpler, like a sinus venosus defect, where an adult cardiac surgeon would often feel that would be appropriate for them to do the operation, and I think that that's something that an ACHD provider has seen enough issues with that specifically understands that is much more complicated than it seems in terms of a surgical repair. And so educating providers in fellowship and beyond of what sorts of situations it's right to reach out, and then being very clear that they should just reach out throughout, and having that relationship and having a clear line where that the community of adult cardiologists mostly who are caring for these patients when they do identify a situation where the expertise would be helpful, I think it's important that they know how to get there. That's really a short-term solution, and there are a number of other short-term solutions that I think we've identified. But over the long term, the hope would be that there's more capacity in order to care for these patients. I don't think we'll ever get away from needing to create networks within communities. And here, I think there's a big distinction in terms of where you are. If you are, let's say, in a certain 2 or 3 block radius in Houston or in Boston, you have multiple centers to choose from. If you're within 50 miles or 75 miles of Cincinnati, there really aren't options. So it will depend a lot on where you are and what sorts of communities and networks need to be developed. And I do think in the end there is some formality to that, especially let's say with maternal fetal medicine and pregnancy, if a center, meaning every center except for Texas Children's doesn't have its own delivery suite for any patient, then I think you do have to have real established collaborations as well as a lot of informal collaborations with most others. I think working with nursing colleagues, nursing staff, nurse practitioners and physician's assistants, administrators, I think are central to this, and other specialists is critical, and it's sort of a long-term goal. In the end, I think that something that isn't often said, and I think that, let's say, Wayne Franklin's smoothness makes it seem like less of an issue, and that is, I think there's always a tension, both on the adult and pediatric side with a lot of these patients, not because people don't want to care, but because they feel uncomfortable. And I think this isn't being recorded, right? So maybe even insecure, but that's not being recorded because it's not what they're comfortable with. I tell you how often, maybe always, when a patient is admitted at the age of 30 to a pediatric institution or has complex congenital heart disease at the adult institution, I wouldn't call it pushback, but there's talkback. And at first it might seem like negativity or disapproval, but when you get down a little bit deeper and have a discussion, it becomes clear that people may not feel comfortable because it's not what they do every day. And so building those relationships and building capacity is critical.
Thank you. I think, and would you like to comment a little bit on what happens to some patients when they see a general cardiologist that doesn't have any experience?
Well, sometimes they get great care. So that's, I think, one thing we have to acknowledge is that, and I think most of the time, just because most of the time we all are lucky, right? And I think that's an important thing to note, that most of the time, if you go to a thoughtful, good doctor, whether cardiologist or not, the care will be good. And I think that in certain scenarios, it may be an appropriate approach when a patient is being cared for in an area geographically that just doesn't have specialists. But on the other hand, there are things like the sinus venosus defect that I mentioned, or certain follow-up for diagnoses that may seem cured to an adult cardiologist, whether it be, say, coarctation of the aorta or tetralogy of flow, where there either is a missing of what the key issues are, or and therefore sort of dropping the ball on identifying an issue before it becomes a major issue that is harder to deal with, or less worrisome or less harmful in the short term, maybe not understanding some of the nuances, such as testing for certain genetic associations with certain diagnoses that may explain other findings in a patient and identify ways to help them in other ways, such as 22q11 deletion in patients with truncal abnormalities, such that they can get more straightforward support for cognitive disabilities or whatnot. So I think that there are a few aspects, and one of the issues, I understand that there is some data to this, but it's a little bit more difficult to identify on the large scale how much harm is being done. And I think that in general, we should focus on the fact that engaging with our adult cardiology colleagues and adult internists and others is probably the best approach, rather than, I think often we will highlight how care is better in adult congenital hands, which may be true, but some care is better than none. And I think while pediatric cardiologists may overestimate this, there's no question that there are some patients who are feeling much more comfortable in their pediatric institution or an adult institution. And if they're in an adult institution and simply won't come back to the pediatric institution, whether that's because they've been treated like a child before with cartoons on television, or because they have a post-traumatic stress that causes them enormous when they come back to the pediatric institution, I think that it's critical to realize that often the adult cardiology care they're going to get is the best care they're going to get, and build that trust and partnership. That said, there is some evidence that care in a pediatric institution with congenital heart capacity does provide improved outcomes surgically and long-term, at least in other countries.
I would like to ask Rosalyn and Jenny Weiner, in the 2008 guidelines on care of adults with congenital heart disease, we had very specific outlines of how often someone needed to be seen in a center and what would be the trigger mechanisms. And it seems in our disjointed world that it's very important for patients to know what signs to look for that really mean that they should go to an ACHD center wherever they find them and whatever they have to do. Rosalyn, Jennifer, and Jenny, would you like to maybe make a comment on that?
Well, I can speak to that a little bit. I think that before 2008, we had no idea what those guidelines would be for us, and even beyond, we're not using those guidelines in our clinics with our doctors, so we don't really know unless we happen to be looped in what we should be looking for in adult centers. Rosalyn mentioned transition earlier, and the thing is that there's not a lot of patients being transitioned in general, so they're uneducated as to what they should be doing as they age. And there's about, I want to say it's 40% of adults report 3-year gap in their care because they don't realize that they should be seeing a certain doctor in a certain program. And they end up re-entering the care system because they have an event that's an emergency, which then they may learn more about the kind of care they're supposed to receive at that point. But sometimes it's too late.
So Rosalyn, if you could comment, but then also we have a question from the audience that you living in LA like I do could answer very well, which is, are there barriers of insurance that create these gaps in care?
Yeah, so the first part of the question, I think, as far as transitioning and not having the education, so if the patient themselves is not being involved in their care as a teenager, they may not even know what, like Jenny was saying, what to look for. And so that's why the education portion of this is quite important to start young. It can start even before that. Something I often tell my parents and families, especially my prenatal patients I see, is congenital heart disease is like learning a new language. We're throwing all these words at you, transposition of the great arteries and tetralogy of Fallot. It's like learning a new language. So the more you practice it, the more you speak it, then the more you learn it. So I think that's important to even start, before the age of 12, like we're talking about. But as far as insurance goes, yes, that's a huge barrier when it comes to transitioning to adult care. And in California, we have a government state-funded insurance that's Medi-Cal, which is Medicaid in most countries, but then, I'm sorry, states, but also in California, we have California Children's Services, and that's like a supplemental insurance that's also state-funded, and but it only lasts until you're 21 years of age. And oftentimes we have patients that have been seeing their pediatric providers until they're 21, then lose that coverage, and then have their county Medi-Cal, which isn't always covered in the county where their provider is. So for instance, we might have some families that live in Central California that come to Los Angeles for their care, but then once the child or now adult turns 21, they don't have the insurance coverage to continue to see us, same providers. Therefore, they just often think, well, I don't have insurance, I don't know who to see. And then that gap in care begins. And then, like Jenny was saying, often the reason they come back into care is an emergency event. They end up in the emergency room because they passed out from an arrhythmia. And so insurance is definitely a barrier. And it's also has to do with education, right? If we don't understand insurance, which, I mean, I'm a nurse and I'm a provider, and sometimes insurance terms are like over my head. And so it's a learning curve for all of us as far as insurance goes.
Okay. Thank you. Kyla Lopez, this is an area of great interest to you, and you've published a lot in this. Could you sort of give us your thinking about this issue, and also the questions that have come in about how this relates to more rural areas, and also how this relates to some of the mental health and psychosocial support that these patients need, and access to care for the whole patient in general?
Well, that's a lot of things in one question. Okay, I'll see if I can tackle it one by one.
Yeah.
From an insurance perspective, obviously this is one of the biggest Achilles heels of ACHD care, because not only are you trying to get access to certain centers that you know that have specialization, but not all centers accept all types of care, A, and B, not all people have insurance in general. And so that's a major issue. And I think there was a perception that perhaps because, the Affordable Care Act extended insurance coverage until the age of 26, that was true if you had commercial insurance, but that was not true if you had public insurance. That's A. And also, not all congenital heart disease centers accept affordable care insurance. So it actually does not necessarily apply to all patients who have that type of insurance. So this is a real problem. This is a health policy issue. And this is the kind of thing that actually needs to be addressed at a state level and at a federal level, because institutions have different contracts with different insurance companies. And in order for people to have adequate access to care, or to have access to quality care in particular, it requires them to have some level of insurance. And so this is an ongoing struggle and an ongoing discussion. I think the Affordable Care Act addressed some of those issues, but obviously there are some things that are left problematic. There are some aspects of charity care that people can access in various hospitals, but certainly that is not enough to deal with the volume of patients that we have. And so this is probably, if we're looking at health policy uses in congenital heart disease across the lifespan, this is probably one of the next greatest issues to tackle, is what do we do with this population that is higher risk and has really a need for subspecialized care. As far as mental health is concerned, we recently published a study looking at mental health in children, and we were looking at what kinds of mental health, if there were mental health disparities in terms of who was getting treated. And what we found was that, number one, as pediatric cardiologists, we categorize things into simple, moderate, and complex, but patients don't necessarily feel that way. When you hear my child has a heart problem, you hear my child has a heart problem, whether it's severe or not. And so we found that children as young as 4 suffer from things, from anxiety and depression at a much higher rate than that of children without congenital heart disease when we compared the two groups. So it's true for younger children. It's true if you have simple disease as well as complex. It increases over the age range. So the older you get, the more likely you are to have these things. And it is grossly I think under recognized, because we do not screen for them. We do not screen for mental health disorders largely. I'm not saying all centers, but in general, that's not something that is generally done in the pediatric cardiology space. Some people say that's not my issue. That's a pediatric issue or an adult issue or a PCP issue. And so I think it behooves us as a field to recognize that not all patients are getting the same kind of care for mental health, not getting it recognized. And furthermore, the last part of this is that the people who were least likely to be diagnosed with anxiety and depression were African-American children, Hispanic children, and Asian children. They were much, much less likely to have a diagnosis and or treatment for these disorders. And we know that in the general population that the prevalence is actually the same for all of those groups. And so we also have a problem with under-recognizing some of these disorders in certain groups. And so there's a lot of work to do in this space.
I agree. And I think when I've looked into it, it seems like one of the underlying problems is that diagnosis and management of both neurodevelopmental and mental health resources are not adequately reimbursed. So those resources just don't exist in the size that we need, particularly for patients with chronic diseases of all types. So one of the things that we need to advocate more aggressively for is the kind of reimbursement that will allow providers to be in that space.
And that's also true for transition. Transition services are largely not reimbursed as an entity. And so once again, from a health policy perspective, this is another thing to tackle. Transition reimbursement, mental health reimbursement. Many mental health services do not accept any type of insurance, be they commercial or public. And so that's also an issue.
And I think that
Did I see your hand go up, Rosa? No, okay, that was, well, we have.
Can I mention one thing?
Yeah.
I just wanted to, I think Dr. Lopez is absolutely right that the access to mental health care is limited, and access to mental health care to providers who have expertise thinking about people with childhood onset heart disease is much, much, much more limited than that. That even if insurance will cover care, I would guess that 95% of those cared for are cared for by psychologists, psychiatrists, social workers who have never seen the inside of a cardiac ICU or seen another patient with heart disease, and themselves may not understand. And perhaps we should be reaching out to people in the community as well, psychologists and psychiatrists and whatnot. I think a lot of programs try to develop a relationship, but my sense is that that's very limited. I just saw Erica Sood pop on Zoom and off, and she's one of several people really pioneering that, along with Adrian Kovacs, Nadine Kasparian, and others.
Well, I think there's another question that's related to that, which is our expectation that patients can care for themselves in adult life and be truly independent depends a lot on both the neurodevelopmental and the psychiatric and other mental health issues they have. And so it would seem that we need at least a way of screening in a more comprehensive fashion so that we can at least pick up the worst problems that and get some sort of oversight, legal steps that are needed, et cetera, that need to be done in the pediatric space before they leave. Because as Karen Stout has said, when she gets those patients and they are now 18 or over, they may resist or refuse to get screening because it's stigmatizing. So if you don't get this established beforehand, there's nothing that can be done on the adult side. And she sees a lot of poor compliance as a result of that. So in terms of coordinating this with our plans for transitioning, it seems like there's a lot of work in this space. I wanted to ask, and then we need to get back to the diversity issue. In terms of advocacy at the federal level for the kind of support that several of you were talking about, reaching into at least the young adult years. Does anybody have feelings about issues related to Medicare for All, or at least extending Title V programs that provide wraparound services later in the early 20s? Does anybody want to comment on that? Okay, all right, we'll go on. I just thought I would throw that in to think about. We have another question, which is, how can we keep ACHD patients of color connected to their clinic even after their surgery or care? Is there something other patients can do? When talking to a Black NP at my ACHD clinic, she mentioned that developing retention for ongoing relationships with their patients of color in particular has been a big struggle. I was told that I am one of the few Black patients that has a long-standing relationship with my team and the clinic. Would anyone like to comment on that question?
I'll take that, Dr. Williams, and I will make one comment on your previous question without getting too political. And I would just say, continue to address your political leaders, your Congress people, your senators, U.S. senators, your state senators. There is a way to do this, Congressman Senator Dick Durbin, from Illinois, was one of the big champions for the Congenital Heart Futures Act. Now it's over 10 years old. So we probably need another big push from some of our political leaders. And that starts at the ground level, right? That starts from us, from our patients, things like that. So I'll leave it at that as a more bipartisan approach. To address this question that you asked about, patients of color and trying to increase awareness in their care. Well, that's as we've seen even from last summer, that remains a real systemic issue with so racial disparities in healthcare. I know Dr. Lopez has published quite a bit on this. And I would just say, as a physician of color, I mean, there's not a lot of us, but that's a start. And I think that we need to continue to address our patients, let them know we're out there, make sure that we're visible, make sure that we're open. But then also we need to I would say, extend our influence or our advocacy at where the patients are. So if you need to go to church or to other places where people may congregate, or where they look for example, I know there's been some studies that have come out looking at trying to increase the awareness in the Black community, and they found that literally barbershops were quite appropriate for looking at some of the areas where Black men are deficient in, which is taking care of the health, looking at hypertension, diabetes, prostate cancer, and they found that putting healthcare information in Black barbershops made a difference. That's where a lot of Black guys go to get their haircut. They want to look good, right? So that's one option when you look at some of the ethnicity and racially related things. But I think, and I know, I think it's very important that someone looks at these issues. But I think we need to start thinking of creative ways. We can't just say, hey, I work at a hospital, come see me. We have to think of creative ways to go let the patients know we exist and we do care for them.
And there is a movement to increase diversity within the cardiology population, and particularly successful in adult cardiology. The Association for Black Cardiologists is a very vibrant group, and there's a lot of energy right now in medical schools to increase the pipeline, particularly for Black, but also Hispanic and Latinx populations. So there's light at the end of the tunnel. Let's talk for a minute about why it's so important to stay in care and why patients get lost and what we can do to bring them back. Maybe, Rosalyn, we'll start with you as to what happens, what are the impacts of being lost to care?
Sure. We touched on it a little bit as far as oftentimes patients tend to feel fine. So they, don't pursue medical care because they feel fine, or maybe they've moved away to college and so they don't have their providers nearby, and, they're moving on with their life and they feel fine until they don't. And they have a sudden cardiac event. And then even pregnancy often is what brings some of our female patients back into care, is that they get pregnant and then they end up in heart failure, or they're having complications with their pregnancy because of their own heart. So all of these things kind of lead to more ER visits and needing more emergent care and being very sick when patients do come back into care because they haven't had the proper care for several years.
And in terms of the members of the team that can make a huge difference in making this easier, the navigation that and the help with problems that patients get within the pediatric system. It's not funded in the adult system. So that seems to be one of the most stark differences between pediatric and adult medicine in terms of how we can do a better job of creating that on the adult side. I think well-developed programs like the ones represented on the panel here have adapted to have those kind of resources within their programs. And that's one of the biggest differences between going to an ACHD center and being seen by a general cardiologist in the community. Wayne Franklin, in terms of getting people back into the system, what can we do more?
Well, I think, again, multi-pronged approach. I think, as Dr. Lopez and the other folks have talked about, good transition programs. So start in pediatric age range and try to have the handoff and the transfer be arranged, and that's been shown to lead to a higher, rate of proper transfer. Getting patients back in, as I mentioned, sometimes you have to go to where they are, and I think we're at a good place right now where there's so much social media and so much digital communication. There's a way to communicate with people just like we're doing now without even have to being where they are. And you can email them, or you can social media, tweet, Instagram post, Facebook post, things like that. I think another thing we can do too, actually, is Craig Broberg mentioned. There's an article that came out in, I think it was Sweden, that looked at putting billboards up and showing that, hey, do you have a scar on your chest, or do you have congenital heart disease? Come see us, right? And they found that actually worked, and some of the people went into the local clinics and hospitals, things like that. Now, I don't know if that would work in the US. I don't know if we even wanted to, and they don't even have a lot of billboards where I live right now, so that wouldn't really be an issue. But I think there's creative ways to do that where we really have to show people that we're here. And again, I think one thing we all need to leverage is our ability to use digital, communication, because that's one thing that we all have. Everybody has a cell phone. Even if you live way out remote, you have a cell phone just about. And I know that was one of the issues in the questions about remote care and things like that in the rural community.
Yeah, I'd like to piggyback off that a little bit and talk about telemedicine specifically. And because of the pandemic, telemedicine has really boomed in not only our congenital heart community, but all of healthcare really. And I think that's a way for providers to be able to reach those people that live far away that can't travel the 400 miles to their ACHD clinic. Having telemedicine visits, is a great way to do it, but that leads into health insurance, right? A lot of health insurance companies didn't know how to cover telemedicine visits and how do they charge for that and what have you. So a lot more needs to be looked into that, and funding needs to be placed on that and that will help us reach more patients.
Jennifer Iguina, I see your head bobbing, and if maybe you could address some of these points as well as what you think families and patients need to be prepared to do before they transfer to the adult system.
Definitely. As a parent, it is very scary to hear that your child has a congenital heart defect. We start at the beginning with our babies. We are parents. We bring them along. We follow this line with them, prepare them. Now, almost 14 years later, it's like I'm starting all over again. And it's so important that my child has the ability to be able to care for himself and prepare for himself. So as a parent, it's important for us to advocate, educate them, prepare them, and make them ready for this transition. It's a big transition for them because you're going to go with them and you're not going to be there anymore. You're not going to be that parent that's going to be able to, hey, come on, let's go to the doctor together. I'm here. You're always going to be there, but you physically are not going to be there. They're going to grow up. They're going to learn new things, and it's important to educate them, prepare them, give them all this opportunity. There's a lot of families that don't have those opportunities to be able to educate their children in that way and prepare them for this transition. And just like Dr. Franklin was talking, it's important that we reach to these families, that we approach these families and we give these families the adequate help that they need, whether it's by internet. Some of these families don't even have access to internet to be able to log on, but it's important for us to reach out to where they're at so we can prepare these children so in the future, just like Rosalyn and Jennifer, they can continue with their healthcare. And that's the most important thing that I think as a parent, it's important. Advocacy is one thing, like Dr. Franklin said, be there, learn, and teach your children, prepare them to be able to deal with the things that they're going to have to deal, because sometimes we're dealing with the health professionals and they might not be at the same page we are. And that happens. Like at the beginning, we said there's words and everything is new to us. And this is going to be new to our kids too. There's so many words that they're not going to understand, so many things that they're not going to understand. But us as a parent, it's our job to help them transition into the adulthood.
Thank you. Stephanie Fuller, you from your standpoint, what do you think patients and families need to know? And feel free to speak on all the surrounding topics about that.
Thank you so much. This is so interesting to me because I think all of us echo a lot of the same things, which is, really prioritizing the patient and making sure that the patient's needs come first. And I think in terms of all these subjects that we discussed are so interrelated. Diversity in the care population helps to establish diversity in the patient population, helps us to understand what the issues are, for example, of the difficulties getting in for appointments if you're a single mother with children at home, or if you're a gentleman who's struggling to get time off from work, and how we can improve our systems and make them more efficient and beneficial towards our patients, bundling visits, bundling exams, trying to do as much by telemedicine and communication, which that's certainly one, if possibly only the silver lining of COVID here, is that we've learned how to communicate in different ways that I think benefit our patients. In terms of what patients need to know when they transition, I think it really is a matter of establishing trust with the patient. And one of the questions that popped up was, okay, relegating the care of a patient that you've had in your care for the first 18 years of their lives to an adult practitioner all of a sudden as a cardiologist or as a surgeon. And I think a lot of those issues have to do with trust. First of all, establishing competency in your care team and realizing that they're people who know what they're doing, that they have your best interest at heart, that they're going to use every resource available to treat you. I think understanding that communication is an important part of that. Now you're establishing a new relationship. So how effectively you communicate with your new patients is going to be a real testament to how much you care about them and that they feel that they have gained your trust as a patient. And lastly, I think the important component of kind of that transition and maintaining patients in your care is, letting them know that we're all kind of learning as we go along here, and that we may not have all the answers for congenital heart disease, but that we work together so well as a community. And this really is a community of care practitioners that is deeply influenced by patients and by patient parents. And that's really, I think, one of the things that sets adult congenital heart disease aside is just how actively involved we are with the patient population.
Well, Stephanie, you might be a neutral party to answer the question of how much of a problem in transition is the pediatric cardiologist not wanting to let go their patient, and how much is all the other obstacles that they see their patient face?
Yeah, I think it can be a huge problem in the sense that, they've told the patients for years, you must always follow with me. I understand your heart disease as a pediatric cardiologist. There's not going to be an adult cardiologist who understands what your form of heart disease is. And so that's kind of gotten ingrained and instilled a little bit in the patients. And to some extent, it's that relationship of knowing that you got your patient through so much as a child that you don't want to risk potentially any kind of adverse care as an adult. So that's where it kind of gets back to us as practitioners needing to also establish a relationship not only with the patient, but with whoever is referring, whether it be a pediatric cardiologist, an adult surgeon who is potentially facing doing a surgery that they're unprepared to do on a patient with adult congenital heart disease. The same goes for the fields of EP, electrophysiology, or interventional cardiology. So being very in tune to kind of not necessarily understanding what limits other practitioners might have, but how we can enhance their ability to take care of complex patients.
Okay.
I'd like to piggyback on this just briefly. You know, when we started our transition program, and we introduced the concepts, you know, for what transition means. It is a whole transition for the parent, because the parent is now moving into a supporting role as opposed to a leading role, and the patient is now moving into a leading role. The people that were the most resistant to our program were the pediatric cardiologists. And so it is a culture shift. There are many institutions where the pediatric cardiologist was grandfathered into the ACHD realm because we did not have ACHD doctors. And so they were de facto ACHD providers. And Dr. Williams, you are one of the pioneers in this area. You as it like helped establish the field of ACHD. And so it has been a real culture shift. That being said, once the pediatric cardiologists understood the why of the importance of this specific training, it's not just, hey, you need to go to see an adult person. It's not as simple as that. There are several layers here in terms of preparing the adult, the parent, preparing the patient. And then furthermore, one of the biggest predictors as to whether or not someone in the pediatric space makes it effectively to the adult space is the endorsement of a pediatric cardiologist for an adult provider. So having a pediatric cardiologist endorse an adult provider, whether they be ACHD or an adult cardiologist, depending on the lesion, is hugely important to them actually making it to the other side. The last thing about this is having in the pediatric cardiology space, there's such a trust that is, you know, over the years and years and years that you've been working with these patients, that addressing some of the issues that are extremely awkward to address when you first meet a new provider, an ACHD provider, is probably best served in the pediatric space. So approaching issues like advanced directives, things like this, talking about birth control, talking about family planning. What does this mean? What are my risks? A lot of these discussions should actually be happening in the pediatric space and not left for the ACHD provider to come in and say, hi, I'm a new doctor. Also, let's talk about these issues that no one's brought up, and this is now incredibly awkward. And it feels awkward to the patient. The patient feels like, whoa, I don't even know you. And you're coming up with these, you're bringing up these topics that are pretty sensitive. And so I think it now that the pediatric cardiologists kind of recognize a lot of the topics that I think we need to broach in this space, I think they are much more willing to participate and have become, I mean, now we are requested constantly to see the patients.
I'm
Wayne,
just going to tag on one quick thing that Kayla said, because when I worked with Kayla in Houston, we found that the absolute worst time to meet the ACHD patient for the first time is in the emergency room. And that's the worst time, but it happens. And I'm going to say that the absolute second worst time would be in the emergency room when she's pregnant. So we definitely have to be prepared a lot better than that. And I know we've all seen patients like that.
I was going to say pregnancy changes the rhetoric of the pediatric cardiologist pretty quickly. I'm sorry, Jenny.
Yeah, I just wanted to add from the patient perspective, the idea of transitioning to an adult. When I was transition age, there was no such thing as an adult congenital specialist. So I was with my pediatric doctor till I was 30 years old. So that became a member of my family, that pediatric cardiologist, and he was there through everything. He knew my family, he knew my grandparents. He'd ask me questions every time I was in clinic. So going from that to an adult congenital doctor who doesn't have as much time to talk to you, who doesn't have as much availability, you sort of feel a sense of not being comfortable, but not belonging there. You feel dismissed to some extent. So that can also lead to adults feeling resistant to transition, regardless of the education they receive. So it's important to, as we mentioned earlier, to build up the capacity of adult congenital doctors as well, to help with that.
I'd like to play a little bit of devil's advocate, really from my own experience on this as well. I transitioned late. I was 27, almost 28 when I transitioned to ACHD care. And at my first visit, they did broach the subject of family planning and birth control and do I want kids in the future? And for me, I didn't feel uncomfortable. I actually was relieved because it never was brought out to me before in my pediatric cardiologist office, and I was in my mid to late 20s. So I think that, yes, what Kayla is saying, that it needs to be discussed in pediatric cardiology with your pediatric cardiologist who you know very well. But also, if we're saying that your pediatric cardiologist is like a part of your family, do you want to talk about birth control with your grandpa? So there's things to think about with that, and where even like the nursing roles can come into that, or social work can come in and help for that, because they're, you know them, but they're not like a member of your family per se. So I think finding other services that can come in and help with these seemingly difficult conversations would be beneficial for patients and their families, really.
And that's actually an excellent point, because we had several pediatric cardiologists who were like, I'm not touching that subject. I don't want to talk about it. Please don't make me talk about that. And so what we did was we partnered with our OB/GYN colleagues and said, for these particular issues regarding family planning and birth control and things of this nature, we are going to refer you to this individual who specifically works with the congenital heart disease population, so that there's shared ownership kind of with the patient, that they're getting the care that they need, but the pediatric cardiologist isn't like, I am not trained to talk about these things, I'm so uncomfortable, but facilitating that relationship with a gynecologist who really who does have that level of expertise, and who can have those discussions. And I would be remiss if I didn't say the other populations that I think are critical that we usually don't speak of in terms of disparities. We talk a lot about racial and ethnic disparities. We often don't talk about issues with the LGBTQ community and the needs that they have and the types of discussions that they need. And the same thing is true for the disability community. There's several nuances there that I think need to be addressed as well.
Well, those are wise words to end on. And I think that one of the takeaways is that patients and their families need to have these very frank discussions with their providers well before their transition age, and have a plan that they all feel comfortable with. And so with that, I think we're just a little bit over time. And so you can cut us off now, Rebecca. Thank you all for wonderful panel discussion. We didn't get to all the topics, but I think it was most important that we respond to the audience's questions. And it's wonderful to have this diverse background experience that we can bring to those questions. And thank you all.
Yes, thank you all
Thank
so
you.
very much.
Thank you.
I think we can all agree we could talk about this for the full 4 hours. So wonderful job. We're now going to take a 10-minute break. And